This talk is about neurometabolic disorders. These are the class objectives. You do not need to read them. We will use them to chart our talk. The talk will be conducted using conversational and question and answer formats. The first question is, a cherry red spot in the context of a degenerative CNS disorder is due to deposition of abnormal compounds in ganglion cells. A true, B false. Metabolic degenerative disorders can be classified based on the prevailing central nervous system findings in two groups. Those with prevailing gray matter findings and those with prevailing white matter findings. We will first talk about gray matter disorders, and in this group we'll consider those producing findings due to cerebral, cerebellar, retina, and spinal brainstem. Cerebral findings. This is a coronal view of the brain. Here you can see the cortex. When affected in patients with degenerative metabolic disorders, we see seizures, dementia, or other type of cognitive problems. I am now broadly pointing to the basal ganglia. When the basal ganglia is affected, we will encounter extrapyramidal signs. Now to the hippocampus. When affected, we see memory problems. Now we're pointing to the amygdala. When affected, we have behavioral problems. And now I am pointing to the thalamus. When involved, we can see many types of problems, mainly involving cognition. Gray matter cerebellar findings produced by metabolic degenerative disorders can affect the cortex or deep nuclei. They manifest by nystagmus and ataxia. The third site of frequent gray matter involvement is in patients with metabolic degenerative disorders is the retina. This is a representation of a dissected eye. Now I have placed a little rectangle in the retina, which I have now enlarged. In certain metabolic disorders, the ganglion cell dysfunction leads to blindness and the appearance of a cherry red spot, as you can see here. Now, in order to explain this finding, I will first describe the histological anatomy of the normal retina. This cartoon representing the fovea and the parafovea will be used for that purpose. I have now included the Muller glia cells just because I don't want you to forget about them. The fovea is where the cones are and ganglion cells are not, and the parafovea where the rods and ganglion cells are present. This neat separation I have represented between the locations of cones and rod is, as you know, not as cut and dry as here represented. Be it as it may, light comes in through the pupil, hits the retina, and light rays go through the retinal layers, reaching the pigmented epithelium and is reflected, giving the retina a reddish appearance that it normally has. As you can see in this frame representing a normal retina. As previously mentioned, patients with degenerative metabolic disorders often have cherry red spot in the retina. This is the result of the ganglion cells being full of abnormal material. This material swells the ganglion cell as represented here, thus making the retinal layer lose its transparency. So when light is presented, only those rays falling in the fovea go through, because in the fovea there are no ganglion cells. Those outside the fovea stop at the retinal outer layer and do not reach the retinal epithelium thus producing the whitish appearance seen in patients with neurodegenerative disorders and cherry red spot. After the retina, we will briefly make some comments about spinal and brainstem involvement in neurometabolic disorders. In neurometabolic disorders, the findings produced by involvement of the spine and the brainstem are hypotonia and motor cranial nerve involvement, especially involving nuclei for extraocular movements. Gray matter diseases include GM1 gangliosidosis, Sandhoff disease, Niemann-Pick C disease, sialidosis, mucopolysaccharidosis, and Gaucher's disease. In other patients, metabolic degenerative disorders produce white matter changes, that is, predominantly white matter changes. Again, this is a coronal cut of the brain. White matter changes involving the pyramidal tract produces spasticity. When involving the visual system, it produces blindness. When involving the U fibers, produce dementia. This is usually very late finding in patients with primarily white matter degenerative disorders. Cerebellum white matter involvement in patients with neurodegenerative diseases usually produce ataxia. Spinal and brainstem involvement, that is white matter involvement, produce spasticity and sometimes signs of cerebral palsy. White matter neurodegenerative disorders include metachromatic leukodystrophy, adrenoleukodystrophy, Graves' disease, Alexander's disease, Canavan's disease, and mitochondrial disorders. So the answer to this question is A. Next question. 4-month-old with a history of slow psychomotor development for the first 2 months of life and regression in the last months, no corneal clouding, hepatomegaly was present. Please take a look at these photographs and answer the following question. What is your diagnosis? A. GM1 gangliosidosis. B. Graves' disease. C. Alexander disease. D. Canavan's disease. This table summarizes the point we have just made. The upper row is for gray matter disease. Here are the structures involved that I previously mentioned. Here, the clinical finding we spoke of a few minutes ago. And here, the diseases that we encounter with gray matter degenerative disorders. Here, we find the structures associated with white matter disease. Here, the symptom produced by white matter disease. And here, the conditions producing white matter disease. We can use this chart to answer the question at hand. Presenting with progressive loss of cognition early in the course of an illness suggests a gray matter disease. Graves' disease, Alexander disease, and Canavan's disease are primarily white matter disorder, as we have just mentioned. Hence, the likely choice is GM1 gangliosidosis. So the answer to this question is A. Next question. Please read the question and then try choosing the correct answers. The vignette is the same as in the previous question, and the question is which organelle is likely involved? A. Peroxisome. B. Mitochondria. C. Lysosome. D. Microtubules. Now we can look at the neuron and remove a segment of the soma to see what is inside of it. And what we find are multiple organelles: Golgi apparatus, The Golgi apparatus is characterized by double-layer membrane with closely packed vesicles. One of the functions of the Golgi apparatus, perhaps the most important one, is to attach carbohydrate that function as addresses to guide cellular elements to their respective destination. We also find lysosomes. Their function is to degrade complex structures, including glycoaminoglycans, formerly known as mucopolysaccharides, sulfatides, gangliosides, and sphingomyelin. Lysosome disorders produce GM1 gangliosidosis. Another cytoplasmatic organelle are peroxisomes. These organelles are in charge of catabolizing multiple substances, including very long-chain fatty acids. The answer to this question is C. Next question. Please, we have here the same scenarios before, so please read it through and then answer the following question. Which enzyme is affected? A. GM1 ganglioside beta-galactosidase. B. GM1 ganglioside neuroaminidase. C. Sulfatase. D. Sphingomyelinase. Although in this question the vignette is similar to the one before, here the possible choices are different. The question is which enzyme is affected. So let's start with the alphabet. I have added an A to the end, which was omitted from the name of this condition, but is part of the name of the compound accumulated in this condition. To understand this term, we need to know the characters involved. These characters are sphingosine, fatty acids, glucose, galactose, phosphocholine, and acetylglucosamine or hexosamine sulfate, and at least one sialic acid or NANA. Now, let's see how we turn this alphabet into words. The G stands for ganglioside. It is called ganglioside because the accumulated substance was first discovered in ganglion cells. Hence, the disease produced by accumulation of this material is called gangliosidosis. This is a normal animal retina. Note the thickness of the ganglion layer. This is a specimen of gangliosidosis produced in the same animal. Notice the difference in the thickness of the ganglion cell in this condition. The question then is, what are gangliosides made of? Gangliosides are made of sphingosine joined to a fatty acid, which is called ceramide. And here is where one of the confusing features of metabolic degenerative disorders start. And the source of the confusion is the use of different names to refer to more or less the same element. The compound we have just mentioned, that is the compound we mentioned as ceramide, is often referred to as cerebroside. In addition to this material, gangliosides have more than one exos, as presented here by two exos, and at least one sialic acid or NANA. NANA stands for a very complicated word that none of us use, hence we will just label it as such. These elements combine to form a nomenclature with four buckets. The first bucket is for the letter G to indicate, as we previously stated, that we are dealing with ganglioside. The next bucket is for NANA, especially for the number of NANA in the compound. And when there is none, we use the letter A for absent. When one, the letter M for mono. When two, D. When three, the letter T. And when four, the letter Q. We often refer to a compound with three or more nana as polysialoganglioside. So the options in this bucket are all the letters we have just mentioned. In the third bucket, we use it for the number of exos, but in a tricky way using the fingers of one hand. When four, we open our hand as indicated here and then close four fingers. In this case, only one finger will be left standing. So we go to the exos bucket and place the number 1. When there are 3 exos, we do the same operation. We use our open hand and shut 3 fingers. 2 fingers are left standing. So we go to the exos bucket and put the 2. When 2 exos are present, we do the hand trick again and bring 2 fingers down. And we're left with 3 standing fingers. Hence, we come to the exos bucket and place a 3. Now we go to the last bucket. And again, we go to nana for answers. But this bucket is to signal the number of nana attached to the first galactose. If it has 1 nana, we use the letter A, which we place in the bucket. If 2, we use the letter B, which we also place in the bucket, as you can see here. So each placement in a GM1A indicates a specific meaning. G tells us that we're dealing with a ganglioside made of sphingosine and fatty acid, with as of yet an undetermined number of exos, but we know more than 1 and at least 1 nana. Then M tells us that there's only 1 nana or sialic acid, which I have added in this frame. Then 1 indicates that there are 4 exos, which include 1 exosamide and 3 exos. The order they are placed in the structure has to be memorized. In this case, it is as you see. Then A indicates that there is only 1 sialic acid attached to the first galactose. So GM1A is formed. So now that we know the letters and we know the words, we need to know how is GM1 made. I have here introduced GM1A. And as you can see, it comes from a similar compound but with many sialic acids. Neuroaminidase remove the excess nana, leaving a single nana and producing GM1. Next question is, how is GM1 catabolized? To answer this question, let's go back to GM1A. Losing a galactose becomes GM2A. The job is mainly done by ganglioside beta galactosidase. Next, the loss of an hexasamide creates a compound that is called GM3A. This is done mainly by beta hexasamidase A. Then, with the loss of a sialic acid, the compound becomes lactocerebrocyte and no longer can be called a ganglioside. This is accomplished mainly by GM3 ganglioside neuroaminidase. Next, with the loss of the last galactose, the compound becomes glucoceramide. This is accomplished mainly by the lactosyl ceramide beta galactosidase. Glucoceramide with the loss of glucose becomes ceramide. This is accomplished mainly by the glucoceramide beta glucosidase. Ceramide then splits by an enzyme called ceramidase into fatty acid and sphingosine. When GM1 ganglioside beta galactosidase is missing or rendered dysfunctional because of GM2 activator protein, a protein that activates GM1 despite being called GM2 is missing, or because saposin B, usually referred to as SAP-B, a protein that protects GM1 ganglioside beta galactosidase, is missing, a block will occur and GM1 will increase and accumulate, producing GM1 gangliosidosis. So the answer to this question is A. Next question. GM1 ganglioside beta galactosidase cleaves galactose only in gangliosides. A true, B false. As we have seen, GM1 ganglioside beta galactosidase transform GM1 into GM2 by cleaving a galactose from the ganglioside, but that is not the only work this enzyme does. This enzyme is also involved in the catabolism of mucopolysaccharides, specifically in the catabolism of keratin. In this frame, I have introduced the elements involved in forming keratin and keratin unit. Notice that galactose also attaches to exosamide in this compound. Hence, in keratin, once NANA is removed, GM1 gangliosidase acts in the bond made by galactose and exosamide, and as it does in the metabolism of gangliosides, splits the galactose. But if beta galactosidase is missing or dysfunctional, as it happens in GM1 gangliosidosis, and as a consequence, no such splitting occurs and keratin increases. This increase produces corneal clouding, cartilage deposition, ligament deposition, and bone deposition that may lead to fractures, and it also produces liver enlargement. So the answer to this question is false. Next question. The dysmorphic features in patients with GM1 gangliosidosis are largely due to keratin deposition. A true, B false. The clinical picture of GM1 gangliosidosis consists of coarse faces, often referred to as gargle-like, developmental delay and hypotonia, enlarged liver, dysmorphic fingers disproportionately thicker at the root than at the tips, cherry red spot, and bone dysostosis. One characteristic finding of bone dysostosis is an anterior notch defect in the lumbar region. This finding is characteristic of all gangliosidosis with bone involvement and of mucopolysaccharidosis. In this frame, you can see a defect in the vertebra being pointed to by the arrow, and also here. GM1 gangliosidosis is an autosomal recessive condition. So the answer to this question is A. Next question. Which is the affected enzyme in Tay-Sachs disease? A. Glucocerebroside. B. Exosaminidase A. C. Alpha-galactosidase A. D. Arylsulfatase A. GM1 gangliosidosis is due to GM1 ganglioside beta-galactosidase deficiency. In Tay-Sachs disease, the enzyme affected is beta-hexasaminidase A. Dysfunction, again, as we said for GM1, can be produced by an abnormality that is partially or total, or also it can be produced by dysfunction due to malfunctioning of GM2 activator or SAPB. Tay-Sachs disease due to beta-hexasaminidase deficiency is an autosomal recessive condition manifested by developmental delay, hyperreflexia, apparent hyperacusia, and cherry red spot. Remember, the macula looks red because there are no ganglion cells in it. The surrounding looks whitish because the ganglion cells are full of ganglioside. Tay-Sachs is restricted to families of Jewish descent. Beta-hexasaminidase A is also deficient in a condition called Sandhoff disease. In this condition, beta-hexasaminidase B, an enzyme needed for the catabolism of globoside, is also affected. CNS symptoms are the same as those seen in patients with Tay-Sachs disease, but patients with Sandhoff disease also have visceral involvement affecting cornea, cartilage, bone, and liver. This condition has no ethnic association. So the answer to this question is B. Next question. A patient with hepatosplenomegaly, pancytopenia, osteoporosis, avascular necrosis of the femur, and bone crisis is likely to have A. GM1 gangliosidosis, B. Tay-Sachs disease, C. Sandhoff disease, D. Gaucher's disease. This question names 4 conditions. 3 of them you have already heard. 1 is GM1 gangliosidosis. As you know, GM1 gangliosidosis is due to GM1 ganglioside beta-galactosidase deficiency. The second condition is Tay-Sachs disease. Tay-Sachs disease is due to beta-hexasaminidase A deficiency. The third condition, Sandhoff disease. In this condition, beta-hexasaminidase A and B are affected. The fourth one is new, Gaucher's disease. The enzyme affected is glucosylceramide beta-glucosidase, as indicated here. As a consequence of this enzyme abnormality, lactocerebroside is increased. The accumulation of lactocerebroside produces a variety of symptoms. To start with, CNS may or may not be affected. If affected, progression may be slow or fast, the latter being greatly disabling in a matter of months, with minimal systemic manifestations. Neurogenic or type 2 Gaucher disease may present with hydrops fetalis. In these patients, the skin is shiny and peels easily. Gaucher type 2 may also present during infancy with retrocolis and trismus. Gaucher type 3 may present in older patients with horizontal gaze palsy and preservation of vertical gaze. Acid phosphatase in serum may be increased in all patients with Gaucher disease, and it may be useful in questionable cases to obtain it when there's a significant degree of suspicion. Non-neurological Gaucher also exists. It courses with a large liver, large spleen, and a large heart. This is an important disease to consider because it's treatable. Look at this patient before and after treatment. Before treatment, the liver and the spleens are enlarged. After treatment, they are no longer enlarged. Bone marrow in these patients show large macrophage with cytoplasm which look like crumbled paper, as you can see in this frame. So the answer to this question is D, Gaucher's disease. Next question, which of the following conditions usually produce angiokeratoma? A, GM1 gangliosidosis, B, Fabry disease, C, Tay-Sachs disease, D, Faber disease. GM1 gangliosidosis, as you know, is produced by a deficiency in ganglioside beta-galactosidase. Tay-Sachs disease is due to beta-hexaxamidase A deficiency. Gaucher disease is due to glucosylceramide beta-glucosidase deficiency. Fabry disease can be remembered by thinking of two. It was described by two physicians, Fabry in Germany and Anderson in England, on the same year, 1989. As you can see here, pointed by the arrow. The second reason Fabry disease can be remembered by thinking of two is that alpha-galactosidase A, here in aqua, is involved in the conversion of globocyte 3 to lactocerebroside, but also in the conversion of globocyte 2 to ceramide. And failure of this enzyme to work produces Fabry disease. The clinical manifestation of Fabry disease are angiokeratoma. These are clusters of angiomas in a characteristic area including the bathing trunk area, lips, and umbilicus. Pain in hands and feet exacerbated by fever, exercise, or heat due to peripheral neuropathy, and hypohidrosis. Progressive renal disease, left ventricular hypertrophy, which I read this EEG is a good example of, and GI problems are common in this condition. The GI problems are due to accumulation of GL3 and GL2 in the Auerbach and Meissner plexus, and also in the circular and longitudinal muscles in the intestine. Fabry is inherited as an X-linked recessive disease. If mother has the gene but not the father, the odds are that if she has two daughters, one daughter will not be affected and the other one will be a carrier. If in addition she has two sons, the preconception odds are that one will be healthy and the second one affected, or vice versa. But if the father has the disease and the mother is not a carrier, all daughters will be carriers because they will all get the bad gene from the father's X chromosome, and the two sons will be healthy since both will have the X chromosome from the mother. So the answer to this question is B. Next question. Which is the affected enzyme in Krabbe disease? A, glucocerebrosidase, B, hexosaminidase A, C, galactosylceramide beta-galactosidase A, D, aryl sulfatase A. Back to the complicated chart of polysialloglycoside catabolism. I have now added a compound called galactocerebroside, nicknamed cycosine. This compound becomes ceramide upon the action of galactosyl ceramide beta-galactosidase, which has a nickname. The nickname is galactocerebroside. When this enzyme is deficient, there will be a block and cycosine will not become ceramide. The consequence is that the patient will develop Krabbe disease. So the answer to this question is C. Next question. Krabbe disease is a white matter disorder. A true, B false. A hypothesis that explains Krabbe disease goes as follows. Here I have represented an oligodendrocyte and a Schwann cell. Both make myelin. The oligo in the central nervous system and the Schwann cell in the peripheral nervous system. I have now represented an oligodendrocyte surrounded by microglia cells, and now added cycosine. When cycosine is accumulated in oligodendroglia cells, microglia cells engulf it, leading to the formation of a globoid cell, which are characteristic of this condition. Hence, the term globoid cell leukodystrophy is often used when referring to Krabbe disease. In the peripheral nervous system, in the Schwann cell, we see now similar event. Here I have represented cycosine. The accumulation of cycosine in the Schwann cell produces an inflammatory reaction leading to peripheral nerve demyelination. The clinical manifestations of this autosomal recessive condition may present in the neonatal period or in the adult period. This is based on the amount of enzyme present. When little is present, as it is in most cases, it presents during the neonatal or early infancy. First signs of upper motor neurons are present, and then later, within a month or years, signs of lower motor neuron become prevalent. Upper motor neuron signs produce delayed development. This represents the motor development of an infant with Krabbe disease. The expected turning is late. Normally, developing infants turn by 5 months. Infants with Krabbe disease do not turn till about 1 year, and from there, gross motor development usually declines, as well as language development, social, and fine motor development. Fundoscopy reveals optic atrophy. It is interesting that in the neonatal period and shortly after, as you can see in this MRI, the optic nerves are thick, as demonstrated by this transverse MRI view, and also in this sagittal MRI view. As the course progresses in these patients, signs of lower motor neuron deficit appears. More often, this occurs in adults in milder forms, since those with the infant form of this condition usually die a few years after their diagnosis prior to developing lower motor neuron signs. So the answer to this question is A. Next question. Which is the affected enzyme in metachromatic leukodystrophy? A. Glucocerebroside. B. Hexaxamidase A. C. Galactosyl cerebrosidase. D. Aryl sulfatase A. Now we're back to the chart. Recall that a defective galactocerebrosidase blocks the conversion of cycosine to ceramide. Then cycosine increases and produces Krabbe disease. Cytosine itself is produced by the action of sulfate upon sulfatide. The sulfatase involved in this process is called aryl sulfatase A, which acting upon cerebroside sulfate, as we have previously mentioned, produces cytosine. A deficiency of this enzyme produces a block leading to an increase in cerebroside sulfate and to a condition called metachromatic leukodystrophy. Metachromatic leukodystrophy is an autosomal recessive condition manifested by upper motor neuron deficit followed by lower motor neuron deficit. But unlike Krabbe, most of the time, this condition presents after a period of normal development. So the answer to this question is D. Next question. Which cell is not found in Niemann-Pick's disease? Look at the three samples shown and decide whether it is A, B, or C. Another compound that needs to go through ceramide to be fully catabolized is sphingomyelin. This is accomplished by an enzyme named sphingomyelinase. When this enzyme is deficient, a block will occur, sphingomyelin will accumulate, and the patient will develop Niemann-Pick disease. Patients with Niemann-Pick disease present with signs of gray matter deficit and a prominent cherry red spot, and in some cases a very large liver. Bone marrow and hematologic studies show lipid-laden macrophage called fomic cells. So the answer to this question is C. Next question. 18-month-old with a history of slow psychomotor development for the first 10 months of life and regression in the last 8 months. Corneal clouding. Hepatomegaly was present. This patient is likely to have A. GM1 gangliosidosis, B. Krabbe disease, C. Hurler's disease, D. Hunter's disease. You already have seen the patient shown in this frame. This frame highlights the most prominent findings in patients with GM1 gangliosidosis. The patient in this question shows many features similar to GM1. Coarse faces, often referred to as gargoyle-like. Hepatomegaly with an umbilical hernia. Developmental delay. Dysostosis multiplex and corneal clouding. But this patient has Hurler's disease. Corneal clouding is very prominent in this condition and more common than in patients with GM1 gangliosidosis. Hurler's is an autosomal recessive condition due to alpha L iduronidase deficiency. One point that helps distinguish Hurler from GM1 is age of presentation. In patients with Hurler syndrome, coarse facial features appeared after 6 months of age. In patients with GM1, facial features become coarse in the first 6 months of life. In this frame, you can see some of the features of Hunter syndrome. Hunter syndrome is due to iduronate 2 sulfatase deficiency. Features are coarse, but they usually are not present until about 2 years of age. Development is delayed, but again, definite signs of developmental delay are not apparent in the first year of life. Behavior is usually aggressive. This is an X-linked recessive disorder. Hence, when mother has the gene, preconceptional chances are that one of 2 daughters will be carriers and one of 2 sons will have the disease. Where if the father has the disease, all daughters will be carrier and both sons will be healthy. Hunter and Hurler's diseases are mucopolysaccharidosis. The cornea is not affected in patients with Hunter disease. So, what causes mucopolysaccharidosis? This is a sample of an enzyme catabolic pathway for mucopolysaccharides. This is the pathway that transforms complex sugar from collagen to simple sugars. The major complex sugars, that is, mucopolysaccharides, are heparan, dermatan, keratin, and chondroitin. These structures undergo changes induced by different enzyme processes that, when malfunction, produce diseases such as Hunter in the case of iduronate 2 sulfatase malfunction, which involves heparin and dermatan, and Hurler's disease in the case of alpha L iduronidase deficiency, again involving heparin and dermatan. So the answer to this question is C. Next question. A 16-year-old boy died. You have been following him for 6 years for progressive ptosis and external ophthalmoplegia. What is the likely cause of death? A. Hypertrophic cardiomyopathy. B. Conductive defect. C. Myocarditis. D. Liver cirrhosis. Such a history should bring mitochondrial disease to your mind. Mitochondria are in charge of many functions. Most importantly among them is the production of energy in the form of ATP. A history of progressive ptosis, as you can see displayed in this frame, from 1998 to 2004, should make us think of the possibility of a mitochondrial defect called Kearns-Sayre syndrome. Patients with Kearns-Sayre syndrome, in addition to having ptosis, they also have progressive external ophthalmoplegia, as you can see in this photograph. Here it is expressed by adduction failure of the left eye when looking up and to the right, and right abduction deficit when looking to the left. Patients with Kearns-Sayre syndrome have a peculiar fundoscopic abnormality, described as salt and pepper changes. Muscle biopsy in these patients show ragged red fibers, here stained using Gomery trichrome stain. They consist of proliferation of defective mitochondria in a variety degree of destruction, giving the appearance of a red rim and speckled sarcoplasm. You can see this appearance here indicated by the arrow, and the speckled sarcoplasm now pointed by the arrow. Patients with Kearns-Sayre syndrome have heart problems consisting of conduction defects. The inheritance of mitochondrial disorders can be due to random occurrence with no apparent family carrier or affected individuals in the family, due to nuclear DNA mutation, in which case the inheritance can be X-linked recessive or autosomal recessive or dominant, or the inheritance of mitochondrial disorders can be as a result of mitochondrial DNA mutation, in which case we use the term mitochondrial inheritance. Kearns-Sayre is among these conditions. Disorders transmitted by mitochondrial inheritance goes as follows. A mother with the genetic trait will pass the mutation to all her children, male or female, where the father with the genetic trait will not pass it to any children, male or female. This is so because all mitochondrial DNA passes from the mother. So the answer to this question is B. Next question. A 15 years old with a history of exercise intolerance, involuntary muscle contractions, and dark urine shortly after the contractions is likely to have A. Pompe disease, B. von Gierke disease, C. Cori disease, D. McArdle's disease. This question touches on 4 conditions. The first one is Pompe's disease or glycogen storage disease type 2. In this condition, glycogen accumulates in the brain, spinal cord, and muscles. In the muscle, it accumulates in skeletal, hard, and smooth muscle fibers. Pompe's disease may present at any age. The infantile form is most frequent. This form presents with hypotonia, hypertrophic cardiomyopathy, decreased awareness, and macroglossia. A frequent exam question is to show you a chest x-ray and ask you to distinguish between Werning-Hoffmann and Pompe's. The one with the large heart belongs to Pompe's disease. Infants with Pompe's disease also have very thick tongues. Infants with Werning-Hoffmann have thin tongue and thin hearts. The enzyme involved in Pompe's disease is acid maltase. This enzyme cleavages glycogen 1,4 linkage, freeing glucose molecules from the polyglucose structure. The second named entity in this question is von Gierke's disease. This condition affects the liver ability to produce glucose from glucose 6-phosphate. The enzyme involved is glucose 6-phosphatase. Malfunction of this enzyme will produce poor glycogenolysis and poor glucogenesis. The kidney is at times involved in this condition, demonstrating focal segmental glomerulosclerosis. Patients with von Gierke's may present during infancy with hepatomegaly. The face is round with fatty cheeks. They often have hypoglycemia, hyperglycemia because low levels of circulating glucose leads to low levels of insulin and subsequent increase in triglycerides. High lactic acid also occurs, and high uric acid because of the elevated lactic acid competes with uric acid for transport at the level of the renal tubules. Liver biopsy will stain heavily for glycogen. The third condition mentioned in this question is Cori disease. Cori disease involves the 2 enzymes listed in this frame. Glucogenesis is intact, blood sugar normal, blood lactate normal, limit dextrin-like structures accumulate in the cytosol of different cell tissues. Patients with this condition resemble patients with von Gierke disease but less severe. The fourth condition is McArdle's disease. This condition is due to skeletal muscle glycogen phosphorylase called myophosphorylase deficiency. Patients with this condition are unable to tolerate exercise. They tire easily, develop painful muscles, and involuntary contractions. During the episode of muscle contraction, urine turns dark due to the presence of myoglobinuria. CPK is elevated during the episodes. Another useful test to diagnose this condition is the lactate ammonia test. In this test, baseline lactic acid and ammonia levels are obtained and plotted in a graph. In this example, only lactic levels will be shown. Then a cuff is placed and inflated to stop arterial blood flow to the hand. Following this, the patient is asked to make a fist on and off for 5 minutes or as long as the patient can stand it. Then the cuff is removed and blood is drawn immediately after the exercise. 1 minute later, then 4 minutes later, and from then on at 5 minutes interval for about a total of 4 or 5 times. In patients with myocardial disease, there will not be a rise in lactate. Normal controls usually have an elevation maximal between 1 and 5 minutes following by progressive decline, as shown in this chart by the green dots. Ammonia levels drawn simultaneously will be increased in control and in patients with myocardial disease. The trend will be similar than the trend for lactate, as shown by the green dots. This frame shows 2 muscle biopsies in patients with myocardial disease. Using H&E stain, the subsarcolemmal spaces look empty, and full when using PAS stain, indicating glycogen deposition. So the answer to this question is D, myocardial disease. Next question, Zellweger disease is a dash disorder. A, lysosomal, B, mitochondrial, C, peroxisomal, D, Golgi apparatus. The answer to this question is peroxisome. Peroxisomes are subcellular organelles that have multiple functions, including the oxidation of very long-chain fatty acids and the catabolism of phytanate, pipecolate, and glycolate. I will briefly discuss 3 conditions involving peroxisomal disorders. The first one occurs in infants. This is a patient with Zellweger disease. Note the pear-shaped head owing to the high forehead and the unusual fullness of the cheeks. And also notice the hypotonic postures as well as the large liver. Organ abnormalities include biliary cirrhosis, polycystic kidneys, retinal degeneration, cerebral neuronal migrational errors, which produce developmental delay, and seizures. The second condition is Refsum disease. I remember this disease by thinking of phyton snakes. Patients with this condition present with retinal degeneration and usually seek medical attention due to progressive visual loss and tiredness. They often have a peculiar shortening of the fourth toe, as you can see in this frame, and very abnormal scaly skin. Biochemically, patients with Refsum disease have impaired alpha oxidation of branch chain fatty acid, hence phytamic acid is very elevated. The skin findings and the elevation of the phytamic acid is the connection with the phyton. The third condition is adrenoleukodystrophy. Adrenoleukodystrophy is an X-linked disorder which is secondary to a mutation in the ABCD1 gene and results in the apparent defect in peroxisomal beta oxidation and accumulation of saturated very long-chain fatty acids. This accumulation occurs in all tissue of the body. This leads to production of reactive oxygen specimen that harm mitochondria and endothelial reticulum, leading to cellular death in multiple organs. This translates into very early symptoms of white matter neurological disease and adrenal insufficiency. This is an MRI of a patient with X-linked adrenoleukodystrophy. Notice that the white matter abnormality has a posterior distribution. This finding is not pathognomonic but is highly suggestive in the right clinical setting of adrenoleukodystrophy. So the answer to this question is C. Next and final question. History of developmental disease, possible seizure this patient is likely to have. Please take a few seconds to look at the photograph below. The possible answers are A. Phenylketonuria, B. maple syrup urine disease, C. homocystinuria, D. alkaptonuria. Patients with alkaptonuria usually present to the dermatologist. nephrologists or rheumatologists because the presence of dark skin pigmentation that increases with time, dark urine, and joint pain. Please watch the osmosis video on homocystinuria, maple syrup disease, and phenylketonuria. In this picture, notice mother hair color and relatively dark complexion. Father complexion and hair was similar or even darker. Her urine had a musty odor. She was intellectually disabled and small for age. She also had frequent rashes and did not like to eat peanut chocolate cookies, which are very high on phenylalanine. So the answer to this question is A. Thank you very much for your attention.